So namaskar दोस्तों.
The supine position of the patient with a bump in the interscapular space, in which position I do interlocking nailing of humerus. With the traction only, with the system, both sides, the traction is given, and external rotation of the proximal fragment is done with the hand only, and you can see in this picture, evident in the fluoroscopy picture, you can see, and I am externally rotating the proximal fragment to see the lateral view of the fracture. So after reduction of the fracture in both AP and lateral view and confirmed on the fluoroscopy picture, we make an we introduced a 2.5 millimeter or 3 millimeter K wire or steamer pin percutaneously at the selected entry point, both in AP and lateral view. The entry point is usually in AP view, it is at the point at the junction of the articular and non-articular fracture. And in lateral view, it is in the line with the intramedullary canal. So, if the fracture is in the upper part, upper fold of the humerus, the entry point is in the AP view, it is in intra-articular surface of the humeral head, because it should be in central in both AP and lateral view. So I am introducing 2.5 millimeter steamer pin percutaneously at the selected entry point. You can see this is the AP view. I am selecting the entry point. It is intra-articular portion of the. You can see in this picture, because the fracture is the upper fourth of the humerus shaft, and this is the lateral view. I am seeing it in the lateral view. It is inside in the line of the intramedullary canal, and it is inside the intramedullary canal in both an AP and lateral view, confirmed in the fluoroscopy picture, and I am exchanging this treatment pin with a guide wire. A 2 millimeter guide wire exchange for this treatment pin, 2.5 millimeter treatment pin, and after making a tag hole, after making a small range,
खराब हो जाना तो हालत खराब हो जाना.
and
इस स्टार सोना सोना ऐसा यार ना होना होना इसकी हाइप इसकी वाइब व्हाट अ कूल पर्सोना इस स्टार सोना सोना ऐसा यार ना होना होना इसकी हाइप इसकी वाइब व्हाट अ कूल पर्सोना हाँ
तुमने जो पुकारा लो मैं आ गया किया जो एक इशारा तो मैं आ गया तारों से भी ज्यादा मेरी छाने की रफ्तार है मेरे नाम से जो ना डर के दिल वो बेकार है भाई तेरा स्टार है यार का यार है भाई तेरा स्टार है यार का यार आ यार आ यार
ऐसा यार ना होना होना इसकी हाइप इसकी वाइब व्हाट अ कूल पर्सोना हाँ
मेरे ही चर्चे मेरा ही शोर है अब आने वाला मेरा ही दौर है एक दिन सलामी देगा मुझे वो करता जो इग्नोर है दुनिया से अलग है मेरा रास्ता जाना है कहाँ ये मुझको अखबार है, मेरी गलती नहीं जो किस्मत गुलजार है। भाई तेरा स्टार है, यारा का यार है, भाई तेरा स्टार है, यारा का यार है, यार है, यार है।
रस्तोगी जब रैपिडो पे टाइम से पहले ऑफिस पहुंचने लगा तो अपने आप को एकदम टॉप मैनेजमेंट समझने लगा।
चाय
कैपुचिनो। क्या सर, टाइम है आने का? चलो।
कैपेचिनो।
ग्रीन टी।
ये है रैपिडो वाला कॉन्फिडेंस। रैपिडो का वाला लो प्राइस, कंफर्टेबल और क्विक। पहली राइड पर 50% ऑफ। अब टाइम से पहुंचो। रैपिडो, बाइक वाली टैक्सी। डाउनलोड नाउ।
This is my right wire is inside the proximal fragment in the proper position inside the intramedullary canal in both the lateral loop, and you can see the fraction is reduced. And take your time while introducing the fracture side, while crossing the fracture side and introducing the right wire in the distal fragment, it should be reduced, the fracture should be reduced in both epi and lateral loops. And now I am inside the distal fragment. Don't put the guide wire inside the soft tissue and don't do try. This is the reading of the intramedullary canal. Serial reading is done. First of all, with the 6 millimeter reamer, and it is being read, and then the 7 millimeter reamer is used up to the lower end of the humerus. It is about up to the 2 to 2.5 centimeter, proximal to the 8 millimeter is reamer is being used. In this picture, as you can see, in epi view, and it has crossed, it is crossing the fracture side. You take the proper time, and the fracture should be reduced while doing reading, and it should not be in varus and valgus position, and it is inside the distal fragment. As you can see in this picture, the 8 millimeter reamer is inside the distal fragment, is introduced. So after reading, we introduce a 7 millimeter nail of appropriate size with hand movement only. Don't use electric reamer or hammer. Only the last few centimeters of the nail is introduced by hammering. So it is a well-placed nail up to about 2 to 2.5 centimeters above the anterior fossa. And now I am deciding where I should put my incision or distal locking. And this is the K-wire position on the skin, put on the skin horizontally, another K-wire vertically overlapping the nail and crossing the hole. So where the both K-wire cross each other, the bisecting point in the middle of the proximal hole, dynamic hole, will be my point of incision in the skin. So after putting about 1 to 1.5 centimeter length skin incision, we do dissection, soft tissue dissection with the fingers or the artiforces, and then a 1.5 millimeter K-wire, sharp K-wire is used to make a hole. After making both holes circular, the lower hole circular and relaxing the upper hole, dynamic hole in the brain as much as possible. And this is the 1.5 millimeter KY is being put to see. This is put in angle because the shape of the anterior surface of the distal humerus is triangular, so it should be put in angle. So introducing in near cortex, we do drilling of the distal cortex through this hole, and after drilling, we have put both the screws. You can see in AP and lateral view, well sized screw and well placed screw inside the hole in both AP and lateral view. So I am putting the proximal screw down. You can see that the nail has been buried about 5 millimeters from the articular surface inside the intramedullary canal. The first screw has been put with the help of the jig and drill sleeve and the sleeve. Both the screws have been put. The well side screw you can see, and I am confirming it in oblique view as a lateral view, even along with the jig. You can see that the jig is in place, and still I am confirming it whether it has gone inside the hole properly or not, and well placed to both the screw inside the both hole, well sided screw in active view, and well placed screw in the lateral view also. So this is the last step. And first of all, I do distal locking because the back hammering of the nail is done when required to reduce the distraction at the fracture site, to eliminate the distraction at the fracture site, and the fracture is compressed. But in this case, there is no distraction at the fracture site. A nail has been buried inside the intramedullary canal about 5 millimeters from the articular surface of the head. So this is the lateral view and AP view of fluoroscopy picture. You can see this is the lateral view, well placed distal screw, well sized distal screw, and this is the AP view. And you can see the final position. There are two skin incisions, one for the entry of the nail and other for the proximal to the screw. So these are the last confirming fluoroscopy picture. You can see the well placed both screw and well buried nail around 5 millimeters from the articular surface. This is a fracture. You can see there is a comminuted fracture. There is no distraction. Okay, thank you.
एक सफर हर रोज शुरू होता है सच की बुनियादी सोच पर। सफर जिसकी शुरुआत मोड़ और मंजिल पर सिर्फ आप और आपकी बात है, और ये आपके हम सफर।
धन्यवाद भैया जी।
न्यूज 18 इंडिया पर देखिए भैया जी का हिंद। अब देखिए न्यूज 18 इंडिया के YouTube चैनल और अपने स्मार्ट टीवी पर।
छपरा के डॉक्टर आरसी ठाकुर ने हड्डी फ्रैक्चर के इलाज में क्रांतिकारी तकनीक विकसित कर देश भर में पहचान बनाई है। उनकी तकनीक से 35 लाख रुपए तक का महंगा इलाज मात्र 35,000 में संभव हो सका है। ऑर्थो सर्जरी में योगदान के लिए गुवाहाटी में आयोजित इंडियन ऑर्थोपेडिक एसोसिएशन के राष्ट्रीय सम्मेलन में उन्हें इनोवेशन अवार्ड से सम्मानित किया गया। यह उपलब्धि छपरा, सारण और बिहार के लिए गर्व की बात है।
इनोवेशन अवार्ड इंडियन ऑर्थोपेडिक एसोसिएशन द्वारा शुरू किया गया है, जो कि गुवाहाटी IOA 25 में दिया गया है, और यह अवार्ड पूरा भारतवर्ष में 3 ऑर्थोपेडिक सर्जन को मिला है, जिसमें बिहार से मेरा ही नाम है। अतः से छपरा जिला में जिला का कोई ऑर्थोपेडिक सर्जन या बिहार का कोई ऑर्थोपेडिक सर्जन को पहले बार सौभाग्य प्राप्त हुआ है जिसमें मेरा नाम आया है।
ये है मिस्टर प्रशांत कुमार जो असम से आए हैं। उनके दाहिने कूल्हे का एक्सरे पिक्चर जैसा कि आप देख सकते हैं काफ़ी डिफॉर्म्ड हो गया है और एक दूसरे में चिपक गया है। कूल्हे का हड्डी, कूल्हे का गोला कप में चिपक गया है और काफ़ी हड्डी बन गया है उनके। इसके कारण काफ़ी रेस्ट्रिक्शन मूवमेंट में उनको हो रहा था। वे ठीक से बैठ भी नहीं पाते थे कुर्सी पर। ये है एक्सरे पिक्चर जिन्हें टोटल कूल्हा उनका बदल दिया गया है ऑर्थो सर्जिकल केयर सेंटर में। और 10 दिन के बाद वो वॉकर पे चल रहे हैं और फिर सीढ़ियों से उतर रहे हैं। इसमें ध्यान ये रखना पड़ता है कि उतरते समय पहले प्रेशर वाले पैर कूल्हा को बदला गया है, उसको पैर रखना, उस पैर को रखना है। उसके बाद अच्छे पैर को रखना है और चढ़ते समय पहले अच्छे पैर को ऊपर रखना है। उसके बाद जिसमें कूल्हा को बदला गया है उसको रखना है। ये अब ऑपरेशन के बाद ये कुर्सी पर बैठ सकते हैं, इवन लो चेयर्स पे भी बैठ सकते हैं और काफ़ी कंफर्टेबल और पेनलेस मूवमेंट ऑफ नी जॉइंट आप देख सकते हैं किस तरह से खुद खड़े हो जा रहे हैं और लो चेयर पर भी आराम से बैठ जा रहे हैं। ये बिना सहारा के 10वें दिन बिना दर्द के चल पा रहे हैं।
The number one myth is interlocking nailing of humerus will severely impair the shoulder function due to rotator cuff damage. The reality is, with proper technique and entry point, the rotator cuff damage can be minimized and shoulder function can be preserved. So the myth number 2 is there is always chance of radial nerve injury as it is a complication for the interlocking nailing of humerus. And it is not a complication for the open reduction and internal fixation for plating. So it is, yes, it is there is risk of radial nerve injury when the fracture is at the spinal groove. There is chance of the radial nerve injury, but in the rest of the part, if the fracture is in the rest of the part of the humerus, there is minimum chance of the radial nerve injury when the instruments like the guide wire, remote, and the nail is introduced after proper reduction of the fracture in the distal fragment. Both AP and lateral view, the fracture is reduced properly. Only then these instruments are introduced inside the distal fragment. And don't allow your instrument to wander inside the soft tissue. So these are the two myths which is associated with interlocking nailing of humerus, and other two controversies whether which position of the patient should be used for the interlocking nailing of humerus. There are three positions. Number one, supine position. When it is used it is comfortable for the anesthesia point of view as well as the surgeons. But the distal locking, which is done by freehand technique, is slightly difficult and tricky because the anterior surface of the distal part of the humerus is triangular. So finding the entry point for the distal locking is slightly difficult because slitting of the drill bit or KY. So it should be at angle, it should be introduced at angle, and then it should be kept in a straight line. So this is the disadvantage of supine position, and in lateral position as well as the prone position, the distal locking is done from the posterior surface, which is flat. So the entry hole, finding the entry point for the distal locking is easy because the surface is the flat, but it is uncomfortable position for anesthesia point of view, and the surgeons, it depends on the surgeon's choice. So I do use supine position for all my interlocking nailing. Number 3 controversy is because it is non-weight bearing bone, so one screw distal and one screw proximal is sufficient. But I use 2 screw distal and 2 screw proximal because the 2 is always better than 1, always stronger than 1. If it is just like the 2 kidney present in human body, if one fails, other start working. So, and 2 engines in the aeroplane, one engine fails, the other start working automatically. So, if one screw is not working, then the other screw will do its work. So, the fixation is better by 2 screw proximal and 2 screw distal. So, friends, these are the advantages of locking nailing over the plating of the humerus, and these are the myths, and these are the controversies whether 2 screws should be put proximal as well as the distal, what position should be used in this talk, and let us get tuned for the next video and subscribe my channel for more update on orthopedic surgery and insight.
Hello friends, I am Dr. RCT Thakur, orthopedic surgeon, Chhapra, Bihar. Today I am going to present my innovative work named Dr. Thakur Innovative Technique of Suprapatellar Nailing of Tibia. Tibial fractures are most common among the long bone fractures in human body. These are usually caused by high energy trauma like fall from height. Study shows Dr. Thakur innovative technique of suprapatellar nailing of tibia is safe, cost-effective method of treatment for metaphyseal tibial fractures. Intramedullary nailing technique is the treatment of choice for diaphyseal fracture of tibia in adults. In treatment of metaphyseal tibial fractures, concerns regarding difficulties with reduction due to anterior deformity becomes a challenge. Suprapatellar nailing becoming popular choice for treating metaphyseal fractures. It is highly specialized surgery and requires very highly specialized instruments, sets and implants that tends to be very costly. Dr. Thakur innovative technique of suprapatellar nailing of tibia delivers 100% satisfactory union of fracture in safe and cost-effective way. No special instrument or jig are required. A protective sleeve and a trocar can be used from PFN A2 set and color-coded infrapatellar tibial nail extractor can be used to introduce the nail in proper position. Between March 2020 to March 2021, Dr. Thakur innovative technique of suprapatellar nailing of tibia conducted on 25 patients to fix their tibial fractures. The patients having tibial fractures with no involvement of articular surface were included in this study. Age of the patient ranged between 18 to 60 years and they had no comorbidities. All surgery were performed after an average of 5.5 days, the range being 3 to 12 days after accident. 2.5 millimeter K wire used as a blocking wire to improve nailing of proximal tibial fractures. The tibial fractures of all the patients was fixed by Dr. Thakur innovative technique of suprapatellar nailing of tibia. This is the flow diagram how Dr. Thakur innovative technique of suprapatellar nailing of tibia done. It is done in semi-extended position, about 20 degree of flexion at the knee joint, either transverse or longitudinal skin incision were given, but longitudinal split of quadriceps tendon done. Knee joint entered from above, trocar and protective sleeve from PFN A2 set inserted. Entry point is just medial to the lateral tibial spine. The guide wire, first malleable guide wire, were introduced after serial reaming, fracture reduction and confirmed by fluoroscopy, mounting of the nail with appropriate size over the color-coded tibial nail extractor done. Introduction of appropriate nail size over the guide wire done in proper position with the help of color-coded tibial nail extractor. Locking both proximal and distal done by freehand technique. No jig were used. Wash and repair of quadriceps tendon done and closure done. These are the pictures how we did our cases by Dr. Thakur innovative technique. These are the instruments, the color-coded tibial nail extractor, protective sleeve from PFN A2 set, trocar and malleable guide wire, and stout and hard guide wire. Reamer, these are the passage of sleeve, trocar and hard guide wire in the retropatellar space in AP and lateral view. Passage of reamer over the guide wire after percutaneous reduction with the reduction forceps in AP view, and this is in lateral view. Nail entry over the guide wire and nail entry in distal fragment in AP view. Nail entry in distal fragment in lateral view, and this both locking screw introduced in proximal fragment. In AP and lateral view, all the three screws introduced in distal fragment by freehand technique. This is the clinical picture. Proximal locking done by freehand technique. follow-up steps. First post-operative day, passive flexion and extension of the knee and ankle joint done. Third post-operative day, active flexion and extension at the knee joint and ankle joint done. 10th post-operative day, patient started walking with the help of walker, non-weight bearing. 6 to 8 weeks post-op, we started partial weight bearing. 12 weeks after operation, we started full weight bearing. Now, the final observation, operative time was in this study 80 plus minus 10 minutes. Range was 65 to 110 minutes. Average fluoroscopy during surgery was 38.5 plus minus 6.5 seconds. The range being 10 to 50 seconds. The average time of funion fracture was 8 weeks after surgery, with fracture healing time was 12 weeks. Average hospital stay was 10 to 12 days. All patients followed up after 2, 3, 6 and 12 weeks. Those who could not return for follow-up, telephonic follow-ups were done and called for follow-up in hospital. No complication were observed, no patient experienced any loosening or breakage of a screw or nail, no one complaint of knee pain, no reduction loss or significant displacement of fracture occurred after surgery. At final follow-up, 21 cases found excellent and 4 good results. In none of the patient, removal of nail was done for any cause. These are the results. Fracture, lower third tibia, APL lateral view, post-op X-ray of lower third tibia, APL lateral view. Fractures, lower third tibia, again second case, APL lateral view, post-op X-ray picture, APL lateral view. This is third case of fracture of upper third, APL lateral view, post-op, and this is the clinical pictures, 3 weeks follow-up. Okay. Fourth case, pre-op X-ray, upper metaphyseal fracture of tibia, and this is the post-op X-ray of upper third fracture of metaphyseal tibia. This is fifth case, the lower third, very low fracture of tibia, and this is the post-op APL lateral view. This is the clinical picture 3 weeks after the surgery. Duration of this surgery, the number of patients included in this study was small. The study was not comparative with the standard technique. The status of cartilage over the patella and trochlea post-surgery has not been evaluated. Thus, furthermore study with larger population and long follow-up time is required to compare this innovative technique with a standard technique of suprapatellar nailing. In this technique, fluoroscopy time was slightly more than the standard technique because both distal and proximal locking were done by freehand technique. Finally, friends, this innovative technique is very cost effective. In fact, no cost is incurred for this suprapatellar technique. Whereas the standard instrument sets are very, very costly. This technique can be adopted in smaller and medium class orthopedic hospital. If the only disadvantage of this technique is the slightly more radiation occurs because the locking both proximal and distal are done with freehand technique. But this can be lessened by gaining more and more experience in freehand technique for locking proximal and distal tibia. Thank you.
Hello friends, I am Dr. RCT Ortho, orthopedic surgeon, Chhapra, Bihar. Today I will give a demo of PFL A2 surgery for an osteoporotic patient for intertrochanteric fracture of the femur. The design of the spiral blade provides a stable fixation of this fracture and you can make mobile our patient. So today let us come to the surgery. This is the X-ray of 72 years male having osteoporosis with a fracture of the intertrochanteric on stable time. And this is the post-operative X-ray of the same patient. And now I am going to start my surgery. The skin incision, before the skin incision, I will drop a line from anterior superior iliac spine down to the table, and another line from the tip of the greater trochanter towards this first line, and the point of bisection of these two lines is the point of incision for this surgery. So I am making an incision at these bisecting points where the two lines bisect. So I am giving incision about 2 centimeters, as you can see in the picture. So I am feeling the correct point of entry. It should be at the junction of the anterior 2/3 and posterior 1/3 in lateral view, and in LT view it is just medial to the greater trochanter in the piriform fossa. So I am feeling with my fingers the correct entry point. So after feeling this, I am confirming, I am introducing a bone owl at the correct point selected, and then I am confirming this whether this bone owl is entering at correct selected point or not in CR picture. So I am introducing the owl in correct position after confirming the entry point in CR picture, both in LT and lateral view. So this is LT view. It is entering in proper selected position, and this is inside the intramedullary canal in correct position, going medially in LT view, and this is hammered
if it is in place inside the intramedullary canal in proper position, confirming in both AP and lateral view. And then I will pull this bone out for 2 centimeters to introduce the guide wire. The depression or groove present in the lateral side will guide this guide wire inside the hole, and the guide wire is entering inside the intramedullary canal along the depression or groove present laterally in the owl. So it is inside the intramedullary canal, well placed in AP view. And now I will remove the owl. So I have removed the owl, and I'm doing reading of the medullary canal. In the osteoporotic patient, the reading is not required. This is for the measuring the size of the intramedullary canal, diameter of the intramedullary canal, to select the correct size of the PFN to nail. So, but this is for measuring. I am reading by number 10 and then number 11, remove, and the size is 11 millimeter diameter, PFN nail selected. And then I am reading with a 15 millimeter reamer because the upper part of the nail is about 15 millimeter diameter. So I am reading this, and my assistant is pushing the reamer sleeve medially so that it goes in correct position. So it has been aimed with 15 millimeter reamer, and now I am introducing the nail of selected size, and I will hammer the reamer with the help of supine drive. I am hammering the nail inside the intramedullary canal so that the hole present in the nail comes in the central position of the neck of the femur in AP view, and the spiral blade can be introduced in central position in AP view. And now I am giving an incision for introduction of a spiral blade, and this is the buttress nut. My assistant is tightening it, and so that it touches the lateral wall of the femur. And then I will introduce a guide wire sleeve, and a hard and a stout guide wire is being hammered in the central position of the neck of the femur. And I'm confirming it whether it has gone in central position in both AP and lateral view. You can see in the picture, it is in very good place. It is central in AP view and central in lateral view also. So I am doing rimming. Some surgeons do rimming up to the lateral cortex only, but I do rimming up to the side of the nail selected. So I have rimmed up to the proper distance, and now I am hammering the spiral blade after confirming it central position in both view. And I am compressing this spiral blade by clockwise movement, and so I am compressing the spiral blade by clockwise movement and removing the screwdriver by anti-clockwise movement. So the spiral blade is introduced in proper position, both anterior and lateral view, and then my assistant is attaching the arm for distal locking on the jig. And after measuring the screw size, I am introducing the drill sleeve for drilling the cortex for distal locking. And this is the 2.5 millimeter guide wire. I am introducing, just perforating the, making a dimple on the lateral cortex. I am hammering this hard and stout guide wire in the lateral cortex. And after confirming it, in CR picture, I am drilling with the power drill, both lateral and the first cortex is drilled, and now second cortex is also drilled. And now I will put a selected size of a screw for distal locking. I am measuring this on the CR. I am measuring the size of the, and now I am tightening the screw, distal screw. The final tightening is done. So confirming in CR picture. The final tightening is being done now. It has been tightened. And now my surgery is over, and I will, this is the AP view. You can see that it is in good position, and this is the lateral view of distal screw. has been introduced in proper position in the hole. And this is the lateral view. The spiral blade has gone in the central position in lateral view also. So I will give a forceful wash of the wound, and finally I will stitch the skin and close the wound in layers. And I am closing the wound. And wound has been closed. Without any drain. And I will mobilize this patient on second post-operative day. This surgery is well indicated for the osteoporotic patient with an unstable type of intertrochanteric fracture, because the very design of the spiral blade provides a stable fixation, and we can mobilize the patient from second post-operative day. So this is the lateral view, and this is the AP view post-operative. So thank you everybody, my anesthetist, my assistant, my supporting staff. I think this is the well-executed surgery for a old osteoporotic patient, for unstable type of intertrochanteric fracture. We can make this patient mobile from second post-operative day, which is usually required. Although this was not a very distressed fracture, but to make the patient mobile, we planned this surgery for this patient. Thank you everybody. Hello friends, today I am going to give a demo of interlocking nailing in fracture shaft femur lower third in a 72 years old female. This patient sustained this injury due to fall on the ground. Usually this fracture occurs due to high velocity trauma in young adults, either due to road traffic accident or fall from height. But in old age, this may happen in a trivial trauma due to fall on the ground. So let us come to the demo of this surgery. This is the X-ray of the same patient having lower third short oblique type of fracture of the shaft femur. As you can see, in the other limb, the patient has been operated, that is interlocking nailing has been done 4 years back for the fracture of the shaft femur. So this time the patient had come to me for the lower third fracture of the shaft femur or other limb. So let us come to the surgery. First of all, I will make an incision just above the greater trochanter, about 2 to 2.5 centimeters diameter, and then after blood dissection of the tissues, I am introducing a bone out just medial to the greater trochanter in the piriform fossa in AP view.
As you can see in the CR picture, and in lateral view, it is at the junction of the anterior 2/3 and posterior 1/3 of the greater trochanter. As you can see in the CR picture, I am having the bone out inside the intramedullary canal so that it can enter in selected exact entry point. And this is the lateral view. You can see that it is at the junction of the anterior 2/3 and posterior 1/3. You can see in the picture and epi view, this is the lateral view, this is the epi view, and this is the lateral view. Again, I have focused to confirm the entry point. And finally, after confirming in the CR picture the correct entry point, I am introducing by a screen movement of the CR, and you can see that this is the epi view. It has gone in correct position, and in lateral view also it has gone in correct position. That is at the point of the anterior 2/3, at the junction of the anterior 2/3 and posterior 1/3 of the greater trochanter. So after confirming it, I am going to introduce still I am introducing the bone out inside the intramedullary canal, and finally a 2.5 millimeter guide wire is being introduced inside the intramedullary canal, just lateral to the bone out, which has been pulled out to make an space in the lateral part of the bone out to introduce the guide wire. And finally, after introducing the guide wire, we removed this bone out, and then after reduction of the fracture with the help of the F tools, my assistant is holding this fracture in proper position, and the guide wire has been introduced in the distal fragment. And after introduction of the guide wire, we are going to ring the medullary canal with the help of 9 millimeter reamer, and it is being rimmed with 9 millimeter reamer, hand reamer, and it has crossed the fracture, and my assistant is keeping the fracture in reduced position throughout the nailing process with the help of the F tool. During nailing process also, it is kept in reduced position, otherwise there may be malalignment of the fracture. And I am doing reading with a 10 millimeter remote and still my assistant is keeping the fracture in reduced position, and I am confirming on the CR whether the fracture is in reduced position or not. And this is in reduced position, the slightly distracted, but in reduced position, in amplitude, and also in lateral view. This is the oblique view. And after performing in the CR in both views, we did drilling up to the lower end of the femur, and finally we removed this fracture with the help of power remote 11 millimeter. Because the patient is old one, so removing is easy. It is just to measure the size of the intramedullary canal, the diameter of the intramedullary canal, so what size of the nail should be introduced so that it can fit in the intramedullary canal. The fitting nail can be introduced. So this is the purpose of reading. Because the patient is old-born osteoporotic, throughout the healing process, healing process, and healing process, the fracture is kept in reduced position by my assistant. And the fracture has been linked up to the upper end of the patella, as you can see in the CR picture. You can see in the CR picture it is reduced